Good evening to all the aspirants present here. So, we shall start the class. The topic for today is gastroenterology, and the speaker for today we have is Dr. Sukhen Samanta, who is Associate Staff Physician in Critical Care Unit in Cleveland Clinic, Abu Dhabi. Sir, you may start now.
Thank you. Good evening, everyone. My name is Dr. Sukhen Samanta. I work at Cleveland Clinic, Abu Dhabi. So today we are going to discuss about the esophageal disorder, mostly with pertaining to achalasia cardia, Barrett esophagus, and esophageal carcinoma in 1 year span. In 1 hour, I'll try to cover as much as the important topics. So I might miss something, but the most of the thing which is essential for your clinical aspect for decision making as well as exam purpose will be covered, I hope. So I'll start with let me just share the screen. So I'll start with the achalasia cardia. So you know the achalasia cardia, this is one of the common and gastrointestinal presentations to the GI outpatient department as well as inpatient. So basically, what is achalasia? So achalasia is it's a neurodegenerative system. So if you come to the anatomical structure in the esophagus, we have the starting from mucosa to adventitia. So in between there are different layers of this neuronal, the enteric nervous systems. So there is called one is the myenteric plexus. So what happened in achalasia? This is a degenerative process where the ganglionic cell in the myenteric neurons were destroyed by unknown pathology, which leading to failure or relaxations of the lower esophageal sphincter, and then subsequently leads to a loss of peristalsis, mostly in the distal part, which may progress to mid part also. What is happening so the most important anatomical things we need to consider that when we have esophagus and we have a stomach, so in the junction, the gastroesophageal junction, the circular muscle, which is very important to maintain the integrity of the flow of the food passage and to prevent the regurgitations. So we have a more tone on the lower esophageal sphincter, and it is maintained with this the enteric nervous system, which is disrupted in this kind of situation. So the annual incidence approximately 1.6 cases per 1 lakh individuals, and the prevalence is 10 in 1 lakh individuals. So basically, this is US data. We don't have data from UK or India, but achalasia mostly diagnosed at the age of 25 to 16. The similar kind of situation also happened in child, which is called the Hirschsprung disease, which involves the anorectal region. Coming to the etiopathogenesis and then etiology. So if we consider it's a primary as well as secondary causes, the primary causes is unknown. So we don't know it's why this neuron particularly affected, but there are secondary other disease which can affect the neuronal system, which leads to this that's motor neuron problem. So we'll discuss that also. So what is happening when there is a degeneration? So degeneration basically happen from the inflammations, and then if you see the histological structure, you will see that the number of ganglion cells is significantly reduced, and then surrounded by lymphocytes and some eosinophils. And what is happening in the pathophysiology? There are two types of cells. One is the cells which produce the nitric oxide, which is inhibitory neurons, and there are one which has cholinergics, which increase the tone. So basically, when the inhibitions, so when the destruction of this nitric oxide produced in neuron, leading to basically the inhibition of the inhibitory, so the more increased tone of this, so relaxation will be impaired in this situation, and and that lead to ultimately loss of peristalsis. There are secondary different causes which can cause also achalasia, like the malignancy, gastric carcinoma, the Chagas disease, which is not frequent in Asian population, more of like South American population. Amyloidosis, sarcoidosis, neurofibromatosis, the neuroendocrine neoplasia, juvenile Sjogren's, chronic idiopathic intestinal obstruction, and the and metabolic disease like Anderson Fabry. These are the situation where we can find the similar kind of picture with achalasia. The main manifestation happens because of the ganglionic loss, and the intensity of these clinical symptoms also depend on the how much the losses of ganglionic cell happen. So loss of peristalsis in the distal esophagus, which leads to relaxation with swallowing is impaired. It's also impaired the esophageal emptying. The most of the symptom achalasia is basically due to the defective the lower esophageal sphincter. So coming to the clinical pictures, if you see how the patient presents, so when you suspect, one should suspect the esophageal achalasia mostly when they have a signs of dysphagia to solid, and then second and then liquid, and so also heartburn. Normally patient, many patients have heartburn situation, but after a trial of PPI also the persistent heartburn should give you a clue that it could be possibilities of this the motility disorder. Or the retained food, if you are doing endoscopy, you'll find a retained food inside the esophagus, and there is an increased resistance to pass a scope. So these are the situation where you should suspect there is a possibility. The most common symptom, they are presented with the dysphagia to solid and liquid, later on subsequently develop weight loss, difficulty breathing, sometimes chest pain, regurgitation of the food, and a small number of patients were presented with aspirations, pneumonitis, and admitted to ICU. So how do you approach? So the diagnostic approach basically is depends on uh, things of manometry. So manometry is the one which is the most diagnostic. So we have the old manometric system, but the in this 21st century we have the high resolution manometry. So high resolution manometry is very important, and we see the elevated median IRP. IRP means it's integrated uh, relaxation period. So integrated relaxation period, the pressure basically. So if it's normally less than 15, if the relaxation period, how we measure? We measure over a 10-second window period, and there is a the machine, they will give update you the resting basically the number of these pressures. On the basis of that, we have divided this diagnostic like two into three classified. The classical one, type 1, type 2, and type 3. We don't need details of this, but yes, management sometimes depends on this classification. That's why this is called the Chicago classifications. They are on the basis of this relaxation and the pressure. And then how much is the peristalsis loss. With that, they divide into type 1, type 2, and type 3. And next come to the role of upper endoscopy. Endoscopy is basically you will see the dilated esophageal. There is a residual food materials, how much the quantity we can see. And then endoscopic ultrasound. This is a new to this domain. Basically, when we do achalasia cardiac endoscopy, and then we are doubtful, we can put an endoscopic ultrasound to see is there any findings. So if there is any more than something in the findings is more of like irregular structures, or the size is bigger, we have a suspicion. So with that, that will help to take the final aspiration through this endoscopic ultrasound. Okay. And then achalasia is basically established by presence of aperistalsis in the distal two-third of esophagus and the incomplete lower esophageal sphincter relaxation on manometry. That means there is a elevated pressure, integrated relaxation pressure by high resolution manometry. Barium swallow, previously we used to do a lot, but now is very less. So, but just for knowledge and exam purpose, we should know what is barium. So findings, we will find that the barium will be that esophagus. The esophagus will be dilated. In the end stage, sometimes it will be significantly dilated. Is called the mega esophagus. It's more than 6 centimeters. We call it mega esophagus. Sometimes there is a narrowing the gastroesophageal appearance. Looks like the bird beak appearance. The exam question can ask. And the loss of peristalsis as well as delays emptying of barium. So these are the findings of barium. So these are the same thing we just combine to a diagnostic evaluation in achalasia cardia, what I told. When we suspect clinically, do endoscopy, and then decide with manometry and then classify. So, coming to the differential diagnosis. So, differential diagnosis. So, the first will be the gastroesophageal reflux disorder. This patient have the very similar symptoms with the regurgitations. And then other things is called the pseudoachalasia. So, what is pseudoachalasia? The pseudoachalasia is like picture like pseudo achalasia cardia, mostly caused by the malignancy, which invade the neural plexus, mostly the adenocarcinoma of the gastroesophageal junction. Patients with pseudoachalasia have the similar manometric findings, but we can differentiate between endoscope and endoscopic ultrasound will help to identify the pseudoachalasia with the real achalasia. Other esophageal motility disorder like the nutcracker esophagus, the hammer esophagus, they are also present with the similar picture like dysphagia to solid and liquids. So esophageal manometric testing will help you to understand and to differentiate between this. What happened to the achalasia patients? So basically, the patient with achalasia will increase risk of developing esophageal cancer, but the risk is not that high. It's relatively less. So the surveillance for esophageal cancer we don't practice routinely. For esophageal patient, these are the guidelines from the American College of Gastroenterology. And without treatment, if we leave the achalasia untreated, basically can develop into dilatations of esophagus, and sometimes it produce the mega esophagus. And approximately 10 to 15% of the patient who undergo treatment for achalasia, uh, basically requiring end stage, may require esophagectomy. So other what are the possible treatment? So we did the natural history that the treatment what we do first prefer is the pneumatic dilatation, laparoscopic hair myotomy, and the POEM, like the parvoral uh, endoscopic myomectomy. These are the considered most effective therapy for type 1 and type 2, which is slightly less severe. Type 3 is the more severe kind of thing. And all the procedure, these are the fancy name, but these are not easily accessible to the smaller hospital. So ideally, it should be performed in the center of excellence. And we at Cleveland Clinic, we are fortunate to see all these patients. With this, we have a dedicated manometry, and we have a dedicated DDI, the GI surgical and the medical specialists. They do all this kind of complex procedure. And then the patient which have any best outcome after pneumatic dilatation are those are age more than 40, female patient, those have the narrow esophageal diameters, and those with a type 2 pattern on manometry. Some small note about the per-oral endoscopic myomectomy. Basically, it's a the operation endoscopic operation through the natural orifice, and nowadays getting more and more popular. So, what's the role of botulinum toxin? The botulinum toxin can be considered for some patients when these the basic things like surgical myomectomy and pneumatic dilatation are not possible or not effective. And lastly, pharmacological therapy, which is the least effective treatment. There are several medication people have tried with the calcium channel blocker, nifedipine, and then other whens the botulinum toxin fail. But for symptom control, yes, the nitrate helps for the chest pain and then the chest discomfort. Sublingual nitrate or isosorbide dinitrate orally, it can help.
চার্জার কই
So
ফোনে? তোমার ফোনে চার্জার?
yes, so
সকালে দেখছি।
yes. Okay, so thank you. So, and then this is the flowchart that I told that normally with this slightly lesser and severe patient, we prefer a myomectomy as well as the dilatations. And sometimes, if we are not able to do that, the botulinum toxin medication can be helpful. So, the society guidelines tell that the patients who are the surgical candidate for achalasia patient. So, it's always better to a surgical myomectomy or POEM rather than botulinum toxin. Patient who are not a surgical candidate, we can try the botulinum toxin injection, and then pharmacological therapy. And pharmacological therapy consider only who is not a candidate for this. And one thing we need to remember that because the esophageal cancer risk is very low, so basically we don't need to do a routine endoscopic surveillance. But most of the basic recommendation are weak recommendation because of the data is not very strong. Next, coming to the Barrett esophagus. So the Barrett esophagus is basically a situation. It's a metaplastic situation. So basically, we know the esophagus starting from the cervical esophagus, thoracic, and the abdominal esophagus. I will divide later when in the malignancy chapter. So what is happening in the normally to the esophageal the membrane are stratified squamous epithelium, but if due to some irritations, this if there is a significant change happen to the mucosa, we change into a columnar epithelium, is called the metaplasia. So this situation is called Barrett esophagus. Why we need to know? Because this is a precancerous condition kind of thing. The most important issues is like because of the chronic gastroesophageal reflux, which lead to chronic acid irritations lead to the mucosal changes. So incidence almost like 5.6% adult have. What are the risk factor? I told that the most important risk factor is the gastroesophageal reflux disorder. So that's very important because it increases the fivefold. It increases the risk factor. So 5 year follow up basically important. And then other possibility who are the more risk for the GERD, basically those have a central abdominal obesity, they are high risk for gastroesophageal reflux. Patient has a family history, smoking, that can lead to basically cancer risk. Esophageal carcinoma, especially the adenocarcinoma, is one of the consequence from the Barrett esophagus, so that's why you are discussing so much. What are the clinical features? So basically most of the cases the clinical features will be asymptomatic, not much symptom you will see. Yeah, so most of the patients have asymptomatic, and then most of the patient when it develops slightly bit, they are presented with mostly gastroesophageal symptoms. And sometimes when it's bit late and develop, they present with dysphagia or dinophagia, and sometimes GI bleed from the ulceration. So how to screen and whom to screen? So we screen for Barrett esophagus in patients who have a multiple risk factor for adenocarcinoma. What are the risk factors? Someone has a hiatal hernia, age more than 50, male sex, chronic gastroesophageal reflux disease, with the white individual, central obesity, smoking, confirmed history in the history of Barrett esophagus, and the family in first degree relatives, and then erosive esophagitis on endoscopy. So patient with the negative screening Barrett esophagus, routine follow-up is indicated basically. So how you do that screening basically? So upper endoscopy with biopsy. The sensitivity of endoscopy for detection of Barrett esophagus basically is related to the length. So how much mucosa is involved, that's very important. So we have two type. One is the long segment, other is the short segment. If it is less than 3 centimeter, it's a long, and less more than 3 centimeter is large segment basically. So how do you identify Barrett? Basically, the Barrett esophagus is suspected if someone has a squamous, like suspected when there is a lesion at the squamous columnar junction, more than 1 centimeter to the like gastroesophageal junction,
నడుస్తుంది
and
మంచి
has
క్లాస్ జాయిన్ అవ్వు అని ఫోన్ చేశారు.
and then basically it's more of like salmon color appearance. Normal columnar epithelium has a reddish color and velvet structure, where the squamous epithelium it's a pale color. But this structure will be slightly different. It will be like salmon color appearance. So if you have a suspicion, you need to take a biopsy. Normally 4 biopsy we take, and at least 4 biopsy you have to take every 2 centimeter segment of suspected Barrett esophagus. So what do we find in this one? That the different type of scenarios like gastric cardiac type mucosa you can find. You might find atrophic gastritis, and then most important is the intestinal metaplasia. So the most important, so on the basis of this histological structure, we have a diagnostic criteria. As per the American College of Gastroenterology as well as the British Society of Gastroenterology, we need a proof of metaplasia by seeing a goblet cell, that. So that's one of the important. The goblet cell is a signs of intestinal metaplasia that should normally not present in the esophagus, so it will be present kind of thing. Okay, so what are the differential diagnosis? So any metaplasia can happen, that will be other than Barrett esophagus. So that will be close differential. But what are the cancer risk? So the cancer risk is basically estimated annual cancer risk with Barrett esophagus. It's a range from 0.1 to 3. With the low grade dysplasia, if you have, then the risk is 0.5% per year. Intermediate grade dysplasia is 0.2 to 1%. And then high grade dysplasia chances of carcinoma is like average 5%, 4 to 8%. So how do you manage? Basically, more of important of preventions. So mostly we give the acid reflux medication, pantoprazole or esomeprazole for the reflux, and then some randomized control trial like as ECT trial have shown that the aspirin and esomeprazole have some benefit of chemo prevention of the Barrett esophagus from gastroesophageal reflux patients. And then we have two type of patient. One is a dysplastic Barrett, other is a non-dysplastic. So the non-dysplastic patients basically need a surveillance endoscopy is, and the surveillance endoscopy depends on the how if the length is more than 3 centimeter every 3 years. If the length is less than 3 centimeter, we do every 5 year. And then low grade basically dysplasia, we have then we suggest endoscopic like eradications. And then if have a indefinite for dysplasia, so then we do endoscopy after 2 months of PPI. We are not very sure, so we get PPI and then do again surveillance. So, and then we should not delay up until 6 months. So give a PPI if you have a doubtful, give PPI, see how the response, and then do the endoscopic this one. The factor should consider like treatment is required mostly for the high grade dysplasia, and then if there is an intramucosal cancer, so treatment is depends on the patient's life expectancy, patient's comorbid conditions, and then how much is the segment involvement, how is the facilities available, the expertise in surgery and endoscopy, and also depends on the patient's preference regards to surgery and endoscopy kind of thing. So most of the high grade dysplasia basically is require some kind of endoscopic eradication therapy. So there are several options like endoscopic ablations with like radiofrequency ablations, endoscopic cryosurgery, and endoscopic resections. Endoscopic resection is kind of surgery, minimally invasive surgery, but it also requires high volume expertise center. The last option will be esophagectomy, which is for high grade dysplasia that remove most of the basically neoplastic tissue as well as the surrounding lymph nodes, but it has a very high morbidity, mortality, or long hospital stay. And then management of the invasive esophageal carcinoma we'll discuss basically during the esophageal uh, cancer. So the three options: one is the surgery, chemotherapy, radiotherapy, and then neoadjuvant chemo, and then adjuvant chemotherapy. All these things we'll discuss next. So I discussed already. This is the surveillance system. So now coming to basically the esophageal cancer, the last talk. So the lot of information is there, but you guys read and then take a note. If you want, I can share the slides. That's not a problem. So, but for exam purpose, I would suggest stick to the main gist important topics. And then I think at the level of master degree, we don't need too much of the studies. With these have a lot of like especially esophageal cancer treatment. There are a lot of randomized control trial, a lot of observation studies. It will confuse you, but whatever the recommendation from the American Joint Committee of Cancer, 8 editions, I just updated that, which is worldwide accepted. So any length of malignancy is length always we measure from the upper incisor teeth, And for the purpose of esophageal cancer description, we divided the esophagus into the cervical esophagus, which normally start from the at the level of the cricoid cartilage to the at the level of the sternum, and then upper esophagus, also upper thoracic, mid thoracic, as well as the lower thoracic, and then we have abdominals. So upper thoracic is basically starting from the sternal up to the level of azagus vein, and then mid thoracic is esophagus from azagus vein to the inferior pulmonary vein, and then the lower thoracic is from basically inferior pulmonary vein to the uh, lower esophageal gastroesophageal junction, and the 2 centimeter from gastroesophageal the gastro esophageal junctions to lower part is called the abdominal esophagus. So esophageal cancer is one of the 8 most common cancer and the 6th most common cause of death worldwide. Squamous cell carcinoma and adenocarcinoma, these are the 2 major cancers. So if you see the incidence, we have the different data from the Western world as well as from the developing nations. Country like India and then South Asian country has more prevalent of squamous cell carcinoma, whereas the Western world, the US, North America had more prevalence of the adenocarcinoma. So you can see this is the data mostly from the Western world, and then the squamous cell carcinoma more common on the upper two-third, and then the adenocarcinoma more common in the distal part. And the most common cause, like most common risk factor for adenocarcinoma is basically this Barrett esophagus, and then squamous cell carcinoma, the smoking and alcohol. But worldwide, as an incidence, like squamous cell carcinoma is the most common cancer in esophagus. So this is the classification I was talking, and then and the different level we have like cervical, then upper, mid, lower thoracic, as well as the abdominal one. So coming to the risk factors, so the risk factor is the smoking. Alcohol is the major risk factor for squamous cell carcinoma, and then Barrett esophagus with intestinal metaplasia is the major risk factor for an adenocarcinoma. And there are plenty of reasons for the risk factor to be described, like alkalosia as well as the any acid like alkalotic stricture, caustic stricture can cause risks of squamous cell carcinoma. The diets was one of the important issues. The diets which has fruits and vegetables uh, contain less fruits and vegetables. Someone who chew the betel nuts, and then has taking food with a high temperature beverage, as well as these are all increase the risk of basically esophageal cancer. Red meat, absence deficiency of zinc, selenium, folate can also lead to, there's a situation called Palmer-Winson syndrome that can also precancerous condition. And then atrophic gastritis, previous history of gastrectomy, human papillomavirus, stylosis, poor oral hygiene, and then all this basically leads to the squamous cell carcinoma. And then also there are familial chances of higher if we have a family member who had previous history of squamous cell carcinoma, and the genetical syndrome like the Peutz-Jeghers syndrome. This is an autosomal system where a lot of hematomatous polyp happened across the GI tract, and then pigmentation around the oral mucosa, and which can lead to and also predominant for the gastroesophageal junction malignancy. Other risk factor is the obesity and metabolic syndrome, but to note that the alcohol is not a risk factor for adenocarcinoma. Okay. Come to the clinical features of esophageal cancer. So we all know that the malignancy leads to basically it depends on the stage. Sometimes initial in the early stage there is no symptoms, and then if you have a locally advanced and metastatic have a different symptoms. Locally advanced patient normally present with the obstructive picture from esophagus leading to dysphagia. When dysphagia happens, so 70% of the lumen is obstructed. So in that case, you have a dysphagia. And then weight loss can happen because of poor intake, or it can happen because of the malignancy itself cause like mm, And then other thing will be sometime patient feel like the food is stuck kind of situation. The regurgitation of saliva and food sometimes cause aspiration pneumonia. Some advanced cases, locally advanced, it affect the laryngeal nerve leading to the hoarseness, cough. Sometimes it's cause the bleeding, and then some advanced stages which invade the trachea, bronchi can lead to a fistula. The cervical esophageal tumor is normally 5 to 6% of the cancer, which normally extend hypopharynx to the sternal notch, and then they are mostly locally advanced, and then they presented with weight loss, dysphagia, and hoarseness. So what are the differential? The possible differential is non-malignancy is like achalacias, any stricture, any wave, esophagitis, other motility disorder, or gastrointestinal stromal tumor, leiomyoma, leiomyosarcoma. So how do you diagnose? Again, the diagnosis is basically biopsy. Clinical, when you have suspicions, we have to, and then biopsy is important. You can do it. You have a suspicion, we can do endoscopy, and if you have a mass or if you have any ulcer, you can take a biopsy from there and it prevent. Or in advanced stage, if there is a metastasis, we can do an and the radiology showing there is mass, secondary mass, we can take a final aspiration, so CT guided aspiration to diagnose. So advanced lesion is normally they are like a stricture, they are ulcerated, basically a mass. Sometimes the circumferential can cause stricture, sometimes the cauliflower like structure which is normally not predominant. So endoscopic visualization is one of the pathognomic, but biopsy has to do to confirm the diagnosis before thinking for any possible treatment. Other new advancement of the endoscopic ultrasound, which is very good, basically to find out the deeper the invasion, how much is invasion, help to guide the staging, and then help to take a decision making regarding the treatment. And the patient with the thoracic esophageal tumor which is above the carina, sometimes we need a help from the bronchoscopy. And the cervical squamous cell carcinoma, we need a laryngoscopy to assess the local disease, how much is the extent, and take biopsy or treatment. So next, coming to the how other diagnostic mode like scan, the CAT scan of the neck, chest, and abdomen is helpful to know the extent of the disease, to see how much how we can grade, and then we, if you're not sure about CAT scan result, we have a now like PET scan, whole body PET scan, basically help to find out the potential source. And sometimes very rare we can do laparoscopic staging for staging, mostly for staging purpose. And then some center have advanced PET scan, they directly do PET scan for detection of metastasis rather than doing the contrast CT, basically. And then if you have a suspicion in PET CT, always go for the CT guided biopsy or endoscopic ultrasound guide biopsy to do that. Okay. And then the diagnostic laparoscopy is very rare. Sometimes we do. And then basically we do not utilize the thoracoscopy is normally not done. Endoscopic ultrasound and the PET scan will be enough for this. And if you endoscopic ultrasound, you have a lymph node. So these there are features which suggestive of more malignancy, like the lymph node size is big. They are more of round, smooth, and poor ecogenic. Then they are more suggestive of like a malignancy. So coming to the stage, so we follow the TNM staging as per the American Joint Committee on Malignancy Cancer. So the tumors that involve the esophagogastric junctions with a tumor epicenter less than 2 centimeters, then we call it esophageal. And if the tumor with like gastroesophageal junction tumors with the main starting the epicenter, if it is more than 2 centimeter from the proximal stomach, then we call it a stomach cancer. So it sometimes it if the gastroesophageal junction is very difficult to tell it's a esophageal or gastric cancer, but the management is not much different. So how to classify? So the TNM staging, the TX is not assessed. T0 means there is no primary tumor. And then in situ, like TIS means in situ only dysplasia. TA1 means involvement of the lamina propria muscularis mucosae. T2 means invasion of muscular propria, sorry. And then T3 is involvement of the outside the adventitia, and T4 is surrounding structure. And the lymph node also, yeah, regional lymph node is involved or not. If no, this is N0. If involvement 1 or 2 region, then it's 1. 3 to 6 region, it's 2. And 3 is the, if we is more than 7 involvement region. And no distal metastasis, M0, M1 the distance metastasis basically. And then is there histological grading also normally we use for the purpose of treatment. Like G1 is a well differentiated, G2 is moderately differentiated, G3 is poorly differentiated. And the location wise, I told that which one is cervical, mid, lower thoracic, and abdominal. We can, so coming to the treatment is very complex, and it's more of like surgical decisions, but you should know the basic principle when to do what to do. That much we expect from you guys for exam purpose as well as for understanding of this the guidelines. But there are many randomized control trial have done which one is better, which one is applicable to subgroup of populations, so may not relevant to you. So more, but the most important for prognostic purpose is esophageal cancer itself has carries poor prognosis. So, and then we have a locally disease and advanced metastasis. Advanced metastasis, the treatment I'm not going to discuss, which have very only palliative chemoradiations. But the locally advanced cancer of the thoracic esophagus, basically, it could be adenocarcinoma or squamous cell carcinoma. The management basically is a multimodal. We do surgery, systemic chemotherapy, as well as radiation therapy. So as per the recommendations, we recommend combined modality therapy rather than surgery alone. If you have a locally advanced treatment, surgery plus combined chemoradiation is normally is a general recommendation. But initial therapy of the, if you have a like malignancy in situ, or if you have like a stage 1 malignancy, so in that case, so first the treatment of choice is surgery. So option include the surgery, basically is esophagectomy or endoscopic resection. It depends on the availability, depends on the tumor size and all this thing. But patient who is not a candidate for surgery, they can be treated with or without chemotherapy. Okay, and then what about the T2? T2N0 stage. So the most of the patient with the clinical T2N0 thoracic esophageal cancer, they are normally operable. So if they're operable, go for the operations, and then post-op, seeing the histology, combinations of chemoradiations is important. And for those with T2N0 thoracic esophageal squamous cell carcinoma, and then those are the relatively low risk. So who are low risk? If the size is small, no lymphovascular involvement, it well differentiated, okay, so in that case surgery is the appropriate alternative. And patient who we complete the initial combination chemoradiotherapy should be assessed for like surgical resections, and then who complete the surgery should be evaluated for then post-operative. After the biopsy will decide to do chemo or so. And then if the advanced stage like T3 and T4, we have a node positive disease, in they are called advanced one. So in that case, obviously, if it is resectable, is mostly resectable, but post resection combined chemotherapy is needed basically. For adenocarcinoma of like T3, T4 or node positive, so and patient who are young, who has a good performance, in that case, this group of the chemotherapy is good. Like you have a 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel. So these are good actually. Then a neoadjuvant. So two terminology you need to know. One is a neoadjuvant therapy, chemotherapy, and other is called the adjuvant therapy. Neoadjuvant means you are giving before the surgery, and adjuvant is after the surgery. Post-op adjuvant surgery could be chemotherapy, could be immunotherapy. Nowadays, are new medications are available. But the older patient who has the multiple comorbidities, who cannot tolerate this medicine side effect, So in that case, the neoadjuvant chemotherapy is appropriate alternative. So bit complex in these situations. So, but the thing you need to remember for basically for squamous cell carcinoma, if it is resectable, just resection. If the advanced stage, basically chemoradiation is needed. Some patients require pre-op chemotherapy to reduce the size of the tumor, and then after resection, see the size, how is the margin, how is the biopsies type, and how much is the involvement of the lymph node. On the basis of that, post-op chemo radiation on adjuvant therapy, these are uh, desirable by oncology physicians. Okay, so ineligible, those are not eligible for surgery. So due to many reasons. So in that case, definitely the chemo radiation is the only appropriate selection. And then other thing is patients who is treated with chemoradiations. So concurrent radiosensitization with weekly carboplatin and paclitaxel is needed. They are slightly lower dose we use, though this radiosensitization, the dose is slightly less as compared to the full dose of chemotherapy. And then role of surgery after the initial. So there are group of patient where we give first chemoradiation, then followed by surgery. So in adenocarcinoma group, patient initially with clinical resectable adenocarcinoma, after initial like chemoradiations, surgery, we can proceed for surgery. Okay. And then for squamous cell carcinoma, for basically if it is resectable, also yes, same thing, we can suggest surgery rather than like only chemoradiations. And then those are not respond to chemoradiation. Okay, so patient, the disease did not respond to initial chemoradiation. Surgery we can try if it is operable, and then follow up we can do with the PET scan, and then we can do follow up with the clinical examinations, basically. So, and then post-operative adjuvant therapy, once you do surgery, same thing, like it depends on the tumor status, the lymph node involvement, lymphovascular perineural invasions, bit complex. So for you guys, it's not not important, but the most important to remember is like the surgery in advance, in early stage surgery plus minus like chemoradiation, and then advanced stage definitely pre neoadjuvant chemotherapy, surgery, and then post surgery adjuvant therapy is recommended for esophageal cancer. So I'll conclude here. So if you have any questions, you can ask me now for 5 minutes, and then maybe if you have any question, this is my email. You can write to me, and then basically I would try to reply this. But as a physician, I would suggest like first read the basic stuff and try to remember the exam perspective as well as the clinical perspective. And then there are several studies have been conducted on especially the esophageal malignancy treatment, so it will confuse you. To make it simple thing, I would suggest just to read the flowchart, which will help you. Thank you.
Well, sir, we have got a question here. It's saying from Rowan Chavan, MRCP, which are the most important topics we need to focus on in esophagus?
As a MRCP candidate, if you are just for as a MRCP candidate, so here you need to focus few things. One is the as a achalasia cardia, most important thing you need to is the manometry. So one important the manometry, and then other important the findings of the Barrett esophageal, like in the barium swallow. That one of the important points. And and then the treatment, like if you have achalasia cardia, what like what will be your approach? What is the option you will be available? Like there will be botulism toxin, there will be nitrate, all these things. But nowadays these are optional, like the last option. So which will be the most important treatment option? Number that one, and then the high resolution manometry, and then achalasia pathophysiology. So this will be for achalasia, and then Barrett esophagus, not much, maybe pictures, and then they like cancer, and then the surveillance, that important for Barrett esophagus. And then for esophageal carcinoma, I don't think they will ask about the grading and then treatment. The word they ask is more like few things they will ask. First of all, the risk factor of the squamous cell, and then the risk factor of the adenocarcinoma. And then the important things, they will ask maybe as Palmer-Vinson, they will ask maybe other risk factors. And then they will ask, will be like in early stage, what are the treatment option is available. And then other things, the one is like, they will give you clinical scenarios, and then according to this stage, what will be the first priority. Like early stage is the surgery, and then the late stage will be the chemo radiations. Okay, so these are the things for esophageal cancer. But to be honest, esophageal cancer, they normally have a less question in MRCP, more question like, for GI, most of the question they ask for the liver, pancreas. Some very less question from esophageal cancer, but more question of like achalasia, treatment options, and then diagnostic options. Okay.
So we have one more question, which is,
Yeah.
are there any sequence in investigation in the diagnosis of achalasias?
Yes, so the first clinical suspicion. So from who's like most important is which patient will suspect the, when they have a clinical suspicion like dysphagia and all these things. So, and in that case, the first option will be, yes, the sequence will be first. So the most important thing, the diagnostic will be manometry. The diagnostic is be manometry, and the supporting will be other endoscopy and all these things. But manometry may not be available in the most of the center. But for question answers, the first will be manometry, the first option. So I can see. I'll come back. So that's the reason I put the flow chart. So to help you. So here, so basically, yeah, why they have put an endoscopy first? Because when you have a clinical suspicion, and there will be endoscopy, and then come to the esophageal manometry, because endoscopy is easily available most of the centers. So for screening, you do endoscopy. For confirmation, we do the high resolution manometry.
Okay, sir. Dr. Naseem Akhtar is requesting to display the evaluation slide of Barrett's esophagus.
Well, this is the Barrett's esophagus surveillance. Yes. So basically, yes. So what we do is, in first do endoscopy, and then if you find something irregularities, if you have, then we need to take a biopsy basically, and then the basis of biopsy. Yeah. So the often 4-quadrant biopsy every 1 centimeter if you have irregularities. If no, often 4-quadrant biopsy every 2 centimeter within the Barrett segment. And then histological findings we have in the dysplasia, or not sure about the dysplasia kind of things. So those who have a basically the long segment one, this is important. So every 3 yearly, every 5 yearly. So you have a long segment, we do every 3 yearly, and those are a short segment, we do every 5 yearly.
Aspirants, do you have any more questions? We can take it right now. So I guess there will be no more questions. So
Uh, Good evening, Sukhen. It's a
Hi, hi.
wonderful class. You have enlightened everything about the topic, and I think everybody will understand, and they have get the good guidance. So thank you, Sukhen. Thank you, Sukhen. Thank you.
Thank you. So yeah, I'll
And
forward
Happy
the
New Year. Happy New Year to
happy
all.
happy New Year, happy New Year. Thank you. Yeah,
thank you, sir.
thank you.
It was a great and wonderful class, quite informative and interactive. Thank you.
Thank you.